So welcome everybody. I'd like to introduce Dr. Audrey McKinlay. She has come to be a great friend of Seabird's by working with our Dr. Anne Glang. Audrey is from, you're in New Zealand, yes Audrey?
I'm in New Zealand at the moment, but I'm at the University of Melbourne in Australia.
Okay, that's why I always get confused. So she's often in New Zealand, but she works at the University of Melbourne in Australia. She has a great expertise in the field of TBI in children and is going to share today about her long-term outcomes for adults and of childhood mild brain injury. So she's got this giant database of people that she's followed from childhood to adulthood, and she's going to share some of that with us today. Audrey has a bunch of largely funded projects investigating the outcomes of children and young people following TBI, and is also a board member for the International Pediatric Brain Injury Society. So we are very fortunate to have made friends with and got to know Dr. Audrey McKinlay, and that is how we bring her to you today. So please utilize this opportunity for somebody from out of the country to ask some questions. And there we go. I'll let you tell a little bit more about yourself if you'd like to, Audrey.
Okay, thank you for that. Sure. So I work at Melbourne, Australia, at the University of Melbourne, but I also work here at Canterbury University because I have research in both groups. My main area of interest is very early childhood mild traumatic brain injury, and that's what I'm going to be bringing to you today. So today I'm going to show you some of my research on the long-term outcomes of mild traumatic brain injury in very early childhood. This is important because mild traumatic brain injury, also referred to as concussion, is the leading cause of injury for children, particularly preschool children. Now, because of its high incidence, if only 10% of children who experience a mild traumatic brain injury would go on to have problems, it would result in a significant burden on the healthcare system and the education system, and of course, more importantly, on the child and family themselves. So I hope by the end of today, you'll have a better understanding of some of the types of outcomes that can occur with children following a mild traumatic brain injury. So I'm going to start into my presentation. Okay, so I'm going to cover today the prevalence of mild traumatic brain injury, just to give you some idea of how many children are actually affected by traumatic brain injury. And I would suggest that around 1 in 5 to 1 in 6 in every classroom would be affected by a traumatic brain injury severe enough to warrant medical attention. Then I'm going to present some of my research on the long-term outcomes of these mild traumatic brain injuries and look at some of the contributors to that, and just end with what the public understanding of mild traumatic brain injury is, because I think that's really important for us to understand how these children are overlooked. Sorry, we're having a bit of trouble with the slide progression, so I'm just going to try to get this right. Shouldn't do that. Okay, so I'm going to use evidence from a birth cohort. So this is a group of children who have been followed from birth here in Christchurch. It's a large group of children of 1,265. It was all the children who'd been born in a 3-month period in 1977. So it's really important and useful, because having a cohort like this means that we can gather information on all children that are injured. And the information on these children was gathered prospectively, so it wasn't just gathered in the context of a traumatic brain injury, but in the context of a more general health and development study, and information was gathered at birth, at 4 months, and at yearly intervals up to age 16, and then again at age 18, 21, 25, 30, 35, and now they're even doing the 40-year follow-up. And I'm going to present just the incident rates over years 0 to 25 for children. And the information for these injuries have been collected from a number of sources. So it's been collected from parents and from the children as they got older, and all their recalls were validated against medical and documented traumatic brain injuries, so that we could be pretty sure that the prevalence that we're presenting is for children who've had a traumatic brain injury, and they're not injuries that have been forgotten. Because what normally happens when we look at prevalence of traumatic brain injury is that we use admissions to hospital, or children who are coming out of hospital, as our way of measuring. But most children don't actually go to hospital. So that's likely to be a massive underestimation of how many children are injured. And at the moment they estimate around 200 to 300 per 100,000. So we wanted to look at the cohort to see if we could validate that number. So this is the overall statistics from the cohort. You can see that 318 individuals accounted for 458 traumatic brain injury events. So children were having more than one event, but 67% were dealt with in the outpatient setting. Now that's really important, because these outpatient children, the ones that are seen at the emergency department, or they're seen by their general practitioner and sent home, they're the children we generally don't count in our statistics. 33% of the injury events were admitted to hospital, and 11% met the criteria for a moderate to severe injury. So if we extrapolate out from that, we get an average yearly incidence rate of 1,750 per 100,000. So that's quite a bit more than 200 to 300 per 100,000 that we estimate from admissions. And the prevalence for children 0 to 25 was nearly 32%, with 12% being hospitalised. So if we look at that in a little more detail in this graph, this is showing the percentages over the years 0 to 25. And the red line is our male participants in the study, and the green line is our females. So firstly, notice that 0 to 5, males and females have a similar number of injuries. But after that, males outnumber females consistently. And by the time they're 25 years old, 40% nearly have had a medically attended traumatic brain injury event, compared to only 27% of the females. And the males account for more inpatient injuries too. They accounted for 75% of the inpatient injuries. So that means that we have a big problem that is usually given a low priority. Lots of children are having these injury events, and a lot of these injury events are not identified. And I think now, with the high attention on sports concussion, this has been compounded, this problem, because we talk about mild traumatic brain injury in terms of sports concussions, and we ignore all the other injuries that are occurring in childhood and their potential outcomes. And I would like to just emphasise here that mild traumatic brain injury is concussion. It is the same thing. It is not different. A lot of people get confused about that, and it means that the public don't understand what these injuries mean and what their outcomes can be. So I'm now going to give you some of the evidence from the birth cohort on the likely outcomes of mild traumatic brain injury. So just the mild traumatic brain injuries. And I hope by the end of this presentation that you will be convinced that a mild traumatic brain injury can have some pretty negative outcomes, because I'm going to be looking at the long-term incidence of criminal behaviour and its association with mild traumatic brain injury. The emphasis of my presentation today is going to be on the very early injuries, so the 0 to 5 year group. I think we can all acknowledge that 0 to 5 is a time of particular vulnerability. It's a time when the brain is in rapid development and children are learning a lot of new skills. So the design is using the birth cohort. It's a longitudinal design, and our aim was to evaluate mild traumatic brain injury in terms of severity of mild traumatic brain injury. So we want to know, is there a level of mild traumatic brain injury for which there is no effect and a level of mild traumatic brain injury for which there is? At the moment, we just group all mild traumatic brain injuries together as if they're the same. We also want to know whether early mild traumatic brain injury, 0 to 5, is a time of particular vulnerability. We want to see whether these outcomes would still occur if we controlled for pre-injury characteristics of the child. So if we controlled for those family characteristics that might increase risk, will we still have an outcome? So the birth cohort is shown by this picture here, consisted of 1,265 children. And we divided these into those children that had had mild traumatic brain injury over 0 to 5, with the remainder forming a control group. So they are children that hadn't had an injury to the head. Our mild traumatic brain injury group were further divided according to the severity of mild traumatic brain injury. So we had an outpatient mild traumatic brain injury. They were children who had been seen by their general practitioner, or they'd been seen at an emergency department and then sent home. They hadn't been inpatiented. And we had an inpatient group. And these are all the children that had had a mild traumatic brain injury and they'd been inpatiented for a period of less than 2 days. So it's important to note about those children that there was no other reason for their inpatient status. So they didn't have a fracture or some other problem. They only had a mild traumatic brain injury, and that's why they were in hospital. So here I've listed our inclusion and exclusion criteria. So they were included in our study if they had a medical diagnosis of concussion as a minimum criterion. So we didn't want to include any children that just had a knock to the head. They had to have a loss of consciousness of less than or equal to 20 minutes. So we want to make sure that we weren't including more moderate injuries. And they had to have a post-traumatic amnesia of less than or equal to 60 minutes. Now we excluded children if they had evidence of skull fractures or a moderate to severe injury, or if they had evidence of child abuse, both pre and post injury, because we know that those children are going to have other issues that are not going to be associated with the mild traumatic brain injury. So what we looked at in this research I'm going to present today is behaviour problems. Now it's been reported in the literature, and teachers and parents consistently report that particularly for children, behaviour problems are the most enduring difficulty that they experience. So in the cohort, we collected information about inattention, hyperactivity and conduct disorder at yearly intervals over years 7 to 13. And we collected that both from teachers and parents. But they reported pretty similar findings, so we combined that. Now, an increasing score indicates that they've got more behaviour problems. So that green line is our reference control group. So those are the children that didn't have a traumatic brain injury. The blue line is our outpatient mild traumatic brain injury. They're the ones that were seen at the accident emergency department, or they've been seen by the general practitioner. And the red line is our inpatient mild traumatic brain injury. Now, first thing to know about this is that there is an overall group difference that is significant. And when we looked at what the difference was, it was that the inpatient children were significantly more impaired than the other two groups, who did not differ in their outcomes. So if you have a mild traumatic brain injury over 0 to 5, over 7 to 13, you're experiencing more problems with inattention and hyperactivity. We looked at conduct disorder There's our inpatient children, and we had the same finding. Our inpatient children were significantly more impaired by teacher and parent ratings in terms of conduct disordered behaviour. So when we presented this information and published it, people were quite surprised to find that mild traumatic brain injury could be associated with ongoing problems. And they had a lot of questions, and I want to share the questions that we were asked with you today. So the first question that was asked was, perhaps there were some pre-injury child and family factors that meant that these children would have ongoing problems. And that's a valid question to ask. And an advantage of having a cohort is that we had a wide range of child and family characteristics that we could use to control for those pre-injury factors. So we knew about the socioeconomic status of the family. We knew whether or not they were in a solo parent family, whether the father or mother had entered and left the family. We knew whether or not the mother had depression or whether the children had had early behaviour problems. And when we used these in our statistics to control for these early characteristics, it didn't make any difference to our findings. So that didn't explain our findings. So the next thing that people asked was, perhaps children who are inpatiented are just have more behaviour problems. They're just more accident prone. So what we decided to do was we took a group of children who'd had just accidents out of that reference control group. So all children who'd just had a fracture and they'd been hospitalised for 0 to 45 days. So if it's just that they're accident-prone children, and that explains the increased behaviour problems, our other accident children should also have these problems. So the yellow line that I'm going to show you is our other accident children. So here it is, and when we analyse that data now, our inpatient children were significantly more impaired than the other three groups, and that's inattention, hyperactivity. And if we look at conduct disorder, we had the exact same finding. So that didn't explain our outcomes. It wasn't just having an accident, it wasn't the residual effects of being hospitalised, and it wasn't the child and family characteristics, so we'd control for those. Now another suggestion that was made was maybe there were other variables that you were unable to control for. And this is a valid comment because I did not randomly assign children to a head injury group. I couldn't do that. These are not randomly assigned children. So we decided to look at this in another way. So what we did was we matched each inpatient child to 3 randomly selected children from the reference group who had identical behaviour scores at age 7. And we did that separately for inattention and conduct disorder. So on those ratings of mother-teacher behaviour ratings. Now you would expect that children who had identical behaviour ratings at age 7 would have similar behavioural trajectories. So here's inattention hyperactivity. So the red line is our inpatient mild traumatic brain injury group across 7 to 13 years on behavioural ratings. And the green line is our reference control matched children. So you can see that they are actually matched at age 7. They've got identical scores. But our inpatient children had higher ratings over time of inattention hyperactivity. And if we look at conduct disorder, we get the exact same finding. Now, there are a lot of very cynical people out there. So someone said that perhaps there are just 1 or 2 very high-scoring people in our inpatient group who were pulling those scores up. So what we did was we divided the group into high-scoring and low-scoring. Now, this makes the groups quite small, so we weren't able to statistically analyse this, but just to give you an idea of what they look like. So here are the groups on inattention hyperactivity. You can see that they are matched at age 7, but if anything, it is children who scored low at age 7 who had the most increase in behaviour problems over time, not those that had scored in the high group, at least for inattention hyperactivity. When we look at conduct disorder, we see that children scoring in the low group and the high group had increasing behaviour problems over time. So what can we take from this information so far? We found that children who'd had a mild traumatic brain injury over 0 to 5 years were rated as having more inattentive behaviours by their parents and their teachers over years 7 to 13. And they were also rated as having more conduct disordered behaviours over 7 to 13. Now someone, or a lot of people have argued actually, that we're only talking about 1 or 2 behaviour problems here. So that's the increase that you're talking about. And should we be concerned about this? Is this relevant in terms of what teachers have to deal with, in terms of what parents have to deal with? Should we be concerned? So we followed the children up to when they were between the ages of 14 and 16. So remember, these are children that had their injury 0 to 5, and the injury was a mild traumatic brain injury. And we looked at psychiatric symptoms over these years. Now this was based on the DSM-III-R, which was used at that time. So we looked at attention deficit hyperactivity disordered symptoms, and we looked at conduct disordered symptoms. And as you can see, as shown by the red line, children who had an inpatient injury were over 4 times more likely to have symptoms consistent with attention deficit hyperactivity disorder, and over 6 times more likely to have symptoms consistent with conduct disorder. We looked at 3 other symptoms. So we looked at substance abuse, anxiety disorder and mood disorder. The only other significant difference was for substance abuse, and children in the inpatient group were over 3 times more likely to have a substance abuse disorder. Now some people have suggested if we just followed our other accident children for a bit longer, they also would have had problems. So we put the other accident children in there. You can see that they were no more likely to have these psychiatric problems than the reference control group. So we followed these children up a bit longer. We wanted to see whether these early behaviour problems would manifest in more serious problems such as criminal activity. So we looked over the years 16 to 25. So children that had had an injury 0 to 5, we're evaluating over years 16 to 25. So firstly, looking at the percentages that experienced alcohol dependence or drug dependence. So the green bar is still our reference group, the blue bar our outpatient mild traumatic brain injury group, and the red bar our inpatient mild traumatic brain injury group. So if you had an inpatient mild traumatic brain injury over 0 to 5, you were nearly 3 times more likely to have an alcohol dependence over years 16 to 25, and over 3 times more likely to have a drug dependence over 16 to 25 years of age. And looking at the reported arrests and property offences and violent offences, again children in the inpatient group were more likely to report violent offences, over 3 times more likely to report property offences, and over 5 times more likely to report having been arrested. You can see that our outpatient group is also statistically significantly different from the reference control there, but when we adjusted that for child and family factors, that significant finding just washed out. It was only the inpatient children who had ongoing problems. So to summarise that first bit, we controlled for pre-injury factors, but we still found evidence of adverse psychosocial and psychiatric outcomes for children with mild traumatic brain injury who had been hospitalised. Now clearly there was a lower level of mild traumatic brain injury for which there were no long-term outcomes. So that outpatient mild traumatic brain injury group, the one that had been seen by their GP or had been seen at the accident emergency department, they didn't have consistent evidence of ongoing problems. They tended to get better and any issues they had did seem to resolve. But conversely, more severe cases of mild traumatic brain injury in preschool children did have an increased likelihood of psychosocial problems and psychiatric outcomes. The question is, why would that occur? This was only a mild traumatic brain injury, and I'd like to put a couple of hypotheses to you. Firstly, it might be that 0 to 5 is a time of early vulnerability. Or it might be that we don't identify these children, so they just don't get any appropriate intervention. Or maybe we just don't identify the symptoms, we don't recognise them, so they're not even given the label of mild traumatic brain injury, and so the association is lost. So looking at early vulnerability, this picture here gives a portrayal of the critical stages of development, and we can see that 0 to 5 is a time of rapid development in the brain. So it may be that if an injury occurs over the years 0 to 5, this is a time of critical development. That means that there will be ongoing deficits. And I would suggest that the solution to this is early intervention, that we need to be aware that the injuries occurred and we need to give appropriate treatment and timely treatment. It may be that we just don't identify injury in very young children. And I'm going to give you some research we've done that might demonstrate why we don't identify them. So young children require adults to identify they've had an injury, and the language ability in young children is not very good. So what symptoms are actually reported, and would that mean that a mild traumatic brain injury was actually identified? So we looked at the parent reported concussive symptoms for children over the age of 2 to 6, and we divided them into 2 to 5-year-olds, shown by the red bar, and 6 to 12-year-olds. And what we found was that parents of 6 to 12-year-olds reported more concussive symptoms overall than parents of 2 to 5-year-olds. So that's the first thing. But also there was differences in the type of symptoms that the parents were reporting. So parents of 2 to 5-year-olds reported just as many symptoms if it was things they could see, so external things. So if it was the child vomiting, a parent of a 2 to 5-year-old was just as likely to report that as a parent of a child that was 6 to 12. But if it was an internal symptom, something like a blurred vision, then parents of 2 to 5-year-olds were much less likely to report that. So it could be that symptoms are just not getting reported because the parents can't see the symptom and the child doesn't have the language to explain what's happening. So we really need appropriate screening instruments for this early childhood injury so that we don't lose these children in the system. And I'd like to end my talk today by looking at public understanding of concussion, of a mild traumatic brain injury. I think that this is an area of problem with the rise of concern around sporting concussion. So we're very concerned around sports concussion, but in that concern we forget that sports concussion is the same as a mild traumatic brain injury, and that children, particularly very young children, often don't get their mild traumatic brain injury via sports. So I think that a lot of people misinterpret concussion and mild traumatic brain injury as being different things, and it causes a lot of confusion. So looking just a broader overview of the research on this, Chapman and colleagues found that the public commonly endorsed incorrect beliefs about mild traumatic brain injury. And in terms of adolescents, Bloodgood reported that although 4 out of 5 had heard about concussion, only a quarter reported really understanding it. And a study in 2016 found that 33% of educators endorsed "don't know" to the statement, when children are knocked unconscious, most wake up with no lasting effects. And in a study we conducted just with members of the public, we found that people were very confused about what these different terms meant. So 28% endorsed experiencing a concussion, but when they were later asked in the same survey if they'd experienced mild head injury or a mild traumatic brain injury, nearly 60% said no. And when we looked at that in a little more detail, we found that the public generally believe that concussion is a milder form of mild head injury, and that mild head injury is a milder form of mild traumatic brain injury. So they don't understand that these terms are all referring to the same type of injury. We've also run a study of 10 statements with the general public. Just 10 things that most people should understand if they're going to be able to identify that a concussion has taken place. So these are the 10 statements. Sometimes symptoms can take hours to show up. Someone with a concussion should be kept awake. A concussion occurs only as a result of a direct blow to the head. Young children will recover better from concussion than adults. Being knocked out is not necessary for concussion. Temporary confusion is not concussion if it clears within 5 minutes. The symptoms of concussion are apparent at the time of injury. An injury is a concussion only when there's a loss of consciousness and there are no long-term effects of concussion. And finally, it's safe to return playing sports as soon as concussion clears. So what we ask people to do is say true to false for each of those questions, and then score out of 10 how confident they are about their answer. So there are the answers to the questions. And most people should understand what these answers are. I recently ran this study with a group of teachers, and one headmaster said that his school was going to pull out of the study because no one could possibly know the answers to these questions. They were far too difficult. But here is the study we ran, and we've run it a number of times. We've run it with adolescents and we've run it with the members of the public. So as you can see, the red ones are the ones that the general members of the public got wrong, and the green ones are the ones they got correct. So the question, sometimes symptoms can take hours to show up, they thought that was false, and they were pretty certain that they were right. Someone with a concussion should be kept awake, they thought that was true, and they were pretty certain about that. And a concussion only occurs as a direct result of a blow to the head. They thought that was true as well. So they got those wrong. The things that they got correct and were very confident about is an injury is concussion only when there's loss of consciousness, and there are no long-term effects of concussion, and it's safe to return in sports as soon as concussion clears. So there's definitely some confusion about what concussion is and what occurs when a concussion occurs. Now remember, children rely on adults to understand this stuff and present them to an accident and emergency department if a concussion occurs. Now you might think that athletes would be more informed than the members of the general public, but that's not correct. When we looked at a large group of athletes, we found that they weren't significantly more accurate in their report of concussive symptoms. However, they were more confident, so they thought they knew more. They were more likely to watch sport, but that was not associated with accuracy. They were more likely to have a friend with concussion, but again, that wasn't associated with accuracy. Importantly, they weren't more likely to attend briefing sessions than any other member of the public. And attendance at a briefing session was not associated with accuracy. So that's really important that we understand that. Accuracy, however, was associated with care-seeking behaviour. So when people start to understand what a mild traumatic brain injury is, they do seek care when an injury occurs. Another place I think that the confusion in the general public occurs is among the medical professionals. So we did a study looking at what hospitals write in their notes after a child has presented for a mild traumatic brain injury. And here are the types of terms used. So there's a variety of terms used interchangeably. One doctor had written that the child had received a blow to the head and lost consciousness, but he did not believe it was a concussion. He didn't say what he did believe it was. Also, we don't give good information to parents when we're handing out leaflets to them. We did a study where we looked at all the pamphlets across Australia and New Zealand that were handed to parents after their child had had a mild traumatic brain injury. So we surveyed 96 hospitals and we found 27 different pamphlets. So hospitals tend to share their pamphlets. Only one of these pamphlets complied with the Centres for Disease Control guidelines. Only one of the pamphlets had a close to ideal readability level, and none included only correct information. Also, the pamphlets were missing information. They didn't have information about when the child should return to play, or how the parents should manage behaviour problems, or when a child should return to school, or what accommodations the child might need if they were returned to school. So where does that leave the public? I think it leaves the public quite confused, and I think that often parents don't understand what a concussion or mild traumatic brain injury is, and I think this is how children get lost, and I think it's how they don't get the appropriate services they need to make sure that there are not ongoing problems. So I'd like to urge us all to start using the correct terminology. Let's call it what it is. It is a mild traumatic brain injury. And if we give out information, let's make sure that the information is correct, that it doesn't have incorrect information. Also, I think that we need to be giving early intervention for children. This wait and see attitude. Let's wait and see if the child will have problems. Let's not give any intervention to begin with. That's not conducive to an early recovery, and I think we need to give early interventions. And I think there needs to be within our system a provision for follow-up. We know that 90% of children will recover spontaneously, and that's fantastic, but there will be 10% of children who will not spontaneously recover, and they will require intervention and assistance, and we need to make a provision for that in our services. And I hope that if we do these things, and if we be more sensitive to the potential for ongoing problems with mild traumatic brain injury, in 10 years we won't be discussing the long-term outcomes of mild traumatic brain injury, and instead the outcomes for these children will be a lot brighter. So thank you, and if any of you want to look up the publications associated with this presentation, they're listed here and they're also available on ResearchGate. So are there any questions?
Audrey, thank you so much for doing that. It looks like we have a bit of a question here. So this is from Terry Carlson from Project Brain. And she says that I got the pleasure of hearing you present this at Vanderbilt, and I'm glad that I attended today as well. Can we all assume that these statistics are the same in the U.S. also? I wasn't sure if we would admit or diagnose differently here in the U.S.
I think that's an interesting question because obviously different hospitals are going to admit on different criteria. So that's a difficult thing. So if we say that only children who are admitted have ongoing problems, but hospitals have a more stringent admittance criteria, that kind of says that it suggests that children in the US that are not admitted won't have problems. I don't think we should be that stringent. What I think we need to be saying is that if there are ongoing problems, we need to be providing input. And that by and large it's going to be the children who have more severe mild traumatic brain injury. But that does, we are only looking at group statistics there. So it doesn't mean to say that none of the children who were in the outpatient did not have problems, or all of the children who were in the inpatient group had problems. So I think we need to be more fluid than that in our interpretation. I think that what the stats are showing us is that some children with mild traumatic brain injury will have ongoing problems.
Okay, thank you.
Does that answer that question?
I believe so. Does anyone else have any questions? Let's see. It looks like I have another question from Wendy. Wendy Friedman. She says, are there any support groups for children and or parents of young children with brain injury? And if so, have you heard about the success of these groups?
I think there are lots of support groups. Different support groups, of course, offer different things, and what we're really asking for is a change in the way mild traumatic brain injury is viewed in children. I'd just like to make a comment about how my presentation was presented. When we first started looking at this, it was expected that no child with a mild traumatic brain injury or a moderate traumatic brain injury would have ongoing problems, and so no services were provided. Now we do provide support and services, but it's not getting into the school system. So yes, there are support groups, but there's not a general acceptance that these children will need accommodations within the school system, or that these children will need support within the family. So I think that the support groups do an excellent job, but we need to expand out the support that the children with problems will need.
Okay, thank you. Any other questions from anyone out there? Feel free to type them into the chat box if you do. I'm going to go ahead and stop recording.